Hi again. So let's continue this lecture, the articulation chapter. We're going to start first by discussing the classes of the synovial joints before we go into specific joints like the temporomandibular, your elbow joint, your knee joint, your hip joint. And so we'll realize together that the synovial joints, even though they're mobile, but they're not all mobile in the same way. Some of them can only slide over each other, and we call those guys planar movements or planar joint because it's only capable of gliding over each other. For example, the joints between the carpal bones or the joints between the tarsal bones. They will only allow slight gliding and sliding between the bones, but no real planar movement, no angular movement rather, and no rotational movement, just gliding, right? With that, we also have what we call axial movements. So the axial movement will allow the joint to move in a single plane or two planes. If it's a single plane, then it will be uniaxial movement. So for example, your elbow joint, you're capable of doing flexion and extension, but you're unable to do abduction and adduction. Therefore, it's a uniaxial movement. Or the kind of joint that will allow you a biaxial movement. And we will see some examples of that, like the saddle joint we have between the first carpometacarpal joint. And we have multi-axial joint, which is the type of joint where the bones can move in more than two planes. So with this, let's just imagine together the kind of movements that the joint is capable of. The first one is just a gliding movement, where one bone will just slide and glide over the other bone, but without really performing angular motion. When it comes to the angular motion, then it depends. Are we doing angular motion only in one plane, in a single plane, or can it do it in two planes or so? And therefore, this will be biaxial, where if it's only one plane, the motion, the angular motion is, then it will be what we call a uniaxial joint. We did talk about the circumduction, if you remember. For example, the one that's allowed by the shoulder and the one that's allowed by the hip, that's a circumduction. And then the rotation is where one bone spins on the other bone, like the joint between the atlas and the axis, the atlantoaxial joint, or the joint between the head of the radius and your ulna, the proximal radioulnar joint. That's a kind of a rotational joint. Okay. So with these motions in mind, it will classify our joints into the following categories, and you will see the pictures of these and more explanation in the following slide. We have plane joints, where the joints only slide over each other. They have almost flat surfaces or slightly concave surfaces, but it's only capable of sliding over each other, not really performing an angular motion. Sort of like the joints you have between the carpal bones or the tarsal bones. Will allow the carpal or the tarsal bones to just slide slightly over each other. Then we have hinged joints. Hinged joints, sort of like the door hinges, where it allows only uniaxial movement. And so to give you an example of a hinge joint, you have your elbow joint, right? Your humeral ulnar joint. And another joint will be your ankle. That's also a hinged joint. A pivot joint in which one bone, and we'll see a picture in a little bit, rotates using the other bone as a pivot. So for example, the joint between the atlas and the axis, the atlantoaxial joint, where the atlas will use the dens or the odontoid process as a pivot to spin over in a rotational movement over the other bone. The second example is the proximal radioulnar joint, where the head of the radius will use the proximal end of the ulna as a pivot, so it can spin over it, right? But it's only rotational. It allows only this rotational movement, but no angular movement. Now we'll see examples of what we call condylar joints, and the condylar joints have convex concave surfaces and allows slight biaxial motion, and we will see some examples like the metacarpophalangeal joints, for example. And we have saddle joints. These will have more free motion because the articular surface, we will see that in the next slide, the two surfaces resemble the letter C or a saddle, and when they latch to each other, that allows more freedom in the motion. So even though they are biaxial joints, still it's much more mobile than what we see in the condylar joint. Another name, by the way, for the condylar joint is ellipsoidal joint. Okay. The last type is the ball and socket, where we had two examples. If you remember from the lectures, we had the shoulder joint and we had the hip joint as perfect ball and socket joints. So here are the types again. So we'll see, for example, let's start with the gliding here, or the planar joint. So we can call it a plane joint, gliding joint, or planar joint. And that's between the intercarpal. So it's an intercarpal joint or intertarsal, between the tarsal bones and each other, will have this type of joint where it allows only sliding, gliding over each other. The next motion will be the condylar, or the next type will be the condylar joint. The condylar joint will have the facet slightly depressed and the other one slightly concave. And that will allow biaxial angular movements, like what? Like the joint between the metacarpal and the phalangeal. We call that metacarpophalangeal joint. Another example is metatarsophalangeal joint, right? So these will be types of what we call condylar, or, by the way, ellipsoidal or condylar joint. The next one will be the saddle joint. See how the shape of the joint is made like a C and another C, and they latch to each other. And with this saddle joint, there is much more freedom of movement. Like what? Like the joint between the trapezium and the first metacarpal joint. The trapezium and the first metacarpal joint. That's a saddle joint. Then we go to the hinge, and if you remember, the hinge is like the hinge of the door. Look at this, where one bone is performing angular movement only in a single axis over the other bone. So here, for example, with the trochlea and the olecranon notch, if you remember, and that will perform to us the angular movement that we have, which is the flexion and the extension of your forearm. Another hinged joint we have is your ankle joint. It would also allow this angular movement. The last type that's left for us is the ball and socket type, which here we are looking at an example where we have the head of the femur, and usually the condylar surface or the articular surface resembles a ball or a sphere, and we also had an example of the shoulder, which is the glenohumeral joint. Okay, so here they are again, just different picture now. So here's a gliding joint or a planar joint, and I told you like the intercarpal joints or the intertarsal joints, but here's another example, which is the sternoclavicular joint, is also a planar joint. A hinge joint is like the elbow. A pivot joint is like the atlantoaxial. Another example is the proximal radioulnar joint, is a pivot joint. Ellipsoidal, or another name for it, is the condylar joint. The saddle joint, where the articular surfaces resemble C and shaped like a saddle, and that allows more freedom in the motion. For example, the joint between the trapezium and the first metacarpal, and then the ball and socket. And here you see an example of your shoulder, of the as a shoulder, as an example of the ball and socket joint. Okay, great. So let's talk together about specific joints that we need to remember together. the temporomandibular joint. What's unique about the temporomandibular joint is the articular cartilage that we have that covers the bones. It's not necessarily hyaline cartilage, so that's an exception to the whole thing about the synovial joints, right? We agree that it resembles hyaline cartilage. Over here it resembles more fibrocartilage. In addition to that, I'm going to have a fibrocartilage disc here. We call that the articular disc, separating the two from each other. That allows more mobility of the joint without really sacrificing the stability. And with this, instead of just moving the joint almost like a hinge joint, you are also able to some extent to perform side-to-side movements, and you can feel that if you put your finger on your temporomandibular joint and perform with your jaw side-to-side motion, you will see that the head of the mandible is actually leaving the joint side to side and coming back, and that's only possible because of the presence of this articular disc. So these are things that make the temporomandibular joint different than the other joints. And by the way, this articular disc is very useful when you open your mouth wide open, because then it will allow the head of the mandible or the mandibular condyle to leave the articular surface, which is in the temporal bone. So it actually will slide in front of it and will allow it to come back. And sometimes this doesn't happen, which can result in joint dislocation, TMJ dislocation. Now, in order to hold the joint together, we will need a very strong capsule, right? And we will need 3 ligaments, and you need to remember those 3 ligaments. So there is a ligament running from the temporal bone into the neck of the mandible, right below the head, and we call that the temporomandibular or lateral ligament. The other ligament will start at the styloid process and almost to the angle of the mandible, and that will be stylomandibular ligament, and finally from the sphenoid bone to the medial aspect of the ramus of the mandible, and we will call that sphenomandibular ligament. So once again, the lateral ligament or temporomandibular ligament, and stylomandibular ligament, and sphenomandibular ligament. Sounds good? All right, so that was our temporomandibular ligament. The next ligament we want to talk about is, I'm sorry, not the ligaments, but the next joints we want to talk about are the joints between the vertebrae. So other than the one between the first and the second, which is an exception to the rule, which we agreed together that it is a kind of a pivot joint. Between the vertebrae, we're going to have 2 types of joints, by the way. One of them is a diarthrotic joint, which is a synovial joint between the superior and the inferior facets, remember? And those joints are synovial joints. That's a diarthrotic joint. The other joint is an amphiarthrosis, which is a symphysis that is between the bodies of the vertebrae. And that will allow only slight movements, and therefore it is called amphiarthrosis. So let's have a look at this. And so we have a joint here between the superior and inferior articular process, or the superior and inferior facet, and that is a synovial joint. On the other hand, between the bodies and each other, the vertebral bodies and each other, we're going to have a large intervertebral disc, and that can perform only an amphiarthrosis type of motion. The intervertebral disc is composed of rings and rings of fibrocartilage. That is a tough kind of cartilage, hard to break and stiff. And the center is soft, more gelatinous, more water in it, less collagen, and much more elastic and reticular fibers in the center. In the center then will be called nucleus pulposus, whereas the outer circles here, the fibrocartilage circles, are called annulus fibrosus. Both of them are forming the intervertebral disc. The discs are not really allowed to herniate forward because there is a very strong ligament anteriorly here, but they usually herniate sideways and backwards, and therefore they can compress on the spinal nerves as they are emerging from the spinal cord, and hence the sciatica and the other symptoms that the person may have. So once again, here is an intervertebral disc, and we agreed that there is annulus fibrosus on the outside and nucleus pulposus, and like I said earlier, this can herniate either sideways or backwards, and that can start to press on the nerves. All right, we did talk about this, which is an example of the pivot joint, which is the atlantoaxial joint, but we also have a synovial joint here between the occipital condyles and the atlas. Okay. We go now to joints of the upper limb, the pectoral girdle and the upper limb. We're going to start with this joint here between the sternum and the clavicle, so we call that sternoclavicular joint. Sternoclavicular joint is a planar joint. It allows only gliding motion. What's nice about it, it also has this articular cartilage, the articular disc. Remember where else we had it? In the temporomandibular joint, we had the articular disc. And even though it's synovial, so that's the second place where we have a fibrocartilage embedded inside a synovial joint. The clavicle is very important because it's supporting your upper limb, your arm, and therefore we need to make sure that it stays in position. How would we do that? We put a very strong capsule, and that strong capsule will have anterior and posterior thickening, and those anterior and posterior thickening, we're going to call them anterior and posterior sternoclavicular ligament. Okay? Anterior and posterior sternoclavicular ligament. We also have a ligament between the two clavicles, and we're going to see that, so it's interclavicular ligament. And then we have a third ligament or fourth ligament between the clavicle and the first cartilage underneath, or the first rib underneath, and that will be costoclavicular. Actually, it is inserted into your costal tuberosity. Some of you were wondering what inserts there and why do we have the costal tuberosity at the costal end of your clavicle. That is why, the costoclavicular ligament. So let's have a look here at the ligaments. So we have, here is a clavicle and another clavicle. We have, this is the anterior view. You can see the interclavicular ligament over here and over there. You can also see the anterior sternoclavicular ligament and the posterior. This is a posterior view. Posterior sternoclavicular ligament. And finally we have the costoclavicular ligament. Again, the sternoclavicular ligament is one of these joints. The sternoclavicular joint, is one of those joints where you have an articular disc. And once again, the sternoclavicular joint, if you think about it, it allows only type of gliding. So it's kind of a planar joint. Okay. Then we go to the shoulder, and before we get to the glenohumeral joint, we will realize that we have also a joint between the acromion and the clavicle. So we need to stabilize that as well. In order to stabilize it, we're going to have a ligament coming from the acromion to the clavicle, so it's acromioclavicular joint, and another ligament coming from the coracoid process to the clavicle, that will be coracoclavicular joint. So here we go. So this guy here is your coracoclavicular joint, and then we have the acromioclavicular, the coracoclavicular ligament, and here we have the acromioclavicular ligament. Sounds good? Then we talk really about the shoulder joint, which is the glenohumeral joint. Glenohumeral joint is going to be formed by the glenoid cavity or the glenoid fossa and the head of your humerus. Now, the glenoid is fairly small, so to increase the size a little bit, you make a ring of cartilage. You will see that in a little bit, called glenoid labrum. And the capsule is thickened, and that will give you, the capsule interiorly will give you that, or around, will give you what is known as the glenohumeral ligament, which is really the thickened capsule will form this glenohumeral ligament. We will see also that we have a very strong ligament coming from the coracoid process to the humerus, and that will be your coracohumeral ligament. These are ligaments that will tie the two together. But in addition to that, we're going to have also the coracoacromial ligament, and that will help in tightening the capsule so the capsule doesn't pop up there, so there will be the upward displacement of your humerus is not going to be allowed because of the presence of this. This will prevent the humerus from moving or sliding into that direction in between the coracoid process and the acromion. So this is important for your shoulder joint, even though it doesn't bind itself into the humerus. Sounds good? The fourth ligament we have is this guy, which is a transverse humeral ligament. So what it does, it transfers the intertubercular sulcus, do you remember the intertubercular sulcus, into a complete canal. And in this canal, you're going to have the long head of the biceps going all the way around and inserting into the supraglenoid tubercle. So because of this, the ligament now cannot pop out, and therefore it stabilizes the ligament in and share in the overall stabilization of your shoulder joint. Sounds good? So once again, the ligaments we have are the glenohumeral joint, which is a thickened capsule. And then we have the coracohumeral joint, which is between the coracoid process and the humerus. And then we have coracoacromial, and then we have the transverse humeral ligament. In addition to those, if you remember, we had group of muscles that help in stabilizing the shoulder joint. In addition, of course, to the biceps, in addition to the long tendon of the triceps, we have what is known as your rotator cuff muscles. These are also very important in stabilizing the shoulder joint. So here we go. As I told you earlier, the glenohumeral joint will be increased a little bit with what we call the glenoid labrum, and I showed you earlier the ligaments, the coracoacromial, the coracohumeral, the glenohumeral, and the transverse humeral ligaments, and the muscles that stabilize and helping to keep the humerus in position. These are your rotator cuff muscles. If you remember, they are the teres minor and supraspinatus, infraspinatus, and subscapularis. These are your rotator cuff muscles. Okay, so if you remember, I told you that the glenoid surface is fairly small, and to increase it, you add a little bit more, and you can see here the glenoid labrum, right? And it's and you see here it adds a little bit to the depth of your glenoid cavity. And if this is damaged and it's associated with any of the damage of the ligaments, or if the ligaments are loose, the shoulder joint is frequently dislocated, and the most common dislocation is inferior dislocation, because you can see it cannot really pop up, it cannot pop backward or anteriorly, but it can very much pop inferiorly like that, and that's the most common dislocation path for your shoulder joint. Okay, I have different pictures, and I included different pictures for you just to show you how the ligaments look like, but it's pretty much what we described, and you can have a look at them at your own time to see those ligaments very clearly as we indicated. So here is an example where we have a dislocated shoulder, and you can see how your glenoid, the head of the humerus became displaced under the glenoid cavity, so just bringing you an X-ray for a displaced shoulder joint or dislocated glenohumeral joint. All right, we go to the elbow joint. So we will have, the elbow joint is between really the humerus and the ulna, or the humerus and the radius. So we call that a humero-ulnar joint or the humero-radial joint. And if you remember, the trochlea and the ulna will be on one side, and the capitulum and the head of the radius will be on the other side. So we also want to stabilize that elbow joint. And how do we do that? We have a ligament on the lateral side or on the radial side. We call that radial collateral ligament that connects the humerus and the radius together. On the medial aspect, we have the ulnar collateral ligament that connects the ulna and the humerus together. And then we have annular ligament that connects the ulna with the radius. It spins around. Anytime we have something that spins around, we're going to call that annulus. And here we have annular ligament. So let's have a look at them over here. So we have ulnar collateral, we have radial collateral, or medial collateral, lateral collateral, same name. And then we have here what we call annular ligament. So again, annular ligament, medial collateral or ulnar collateral, and then we have the radial collateral. Of course, all of that is in addition to your capsule, and in addition to the biceps, in addition to the brachialis, in addition to the triceps on the back. All of that is going to be able to help stabilizing the joint. Unfortunately, in little kids especially, this joint, even though it's very hard to dislocate, it can be dislocated, especially the joint between the radius and the capitulum. That gets dislocated also in baseball throwers because of repeated injury and a very aggressive pulling of the radius away from the capitulum. That can form to us what we call nurse-made elbow. And to fix it, they perform a surgery which is called Tommy John surgery, which is named after a pitcher who had repeated injury of his elbow, and where the head of the radius will slip off the annular ligament. And that's also like if a kid falls off a monkey bar, or if the parents are swinging. I think I have a picture here. If the parents are swinging the kid doesn't have still the muscles to hold things together. So unfortunately, sometimes the head of the radius would slip off the annular ligament. As I told you, we called that the nurse-made elbow. Okay? All right. Then we go to the lower limb. The hip joint is an example of the ball and socket joint. It's a diarthrosis, of course. And again, because of the increased mobility that we have here between the acetabulum and the head of your femur, we need to make sure that it stays in place, right? So how would we do that? We have 4 ligaments here, and we have a 5th one I will show to you when we get to the picture. So it's a joint between the os coxa and your femur, or the head of the femur. So actually it includes also the neck. It goes all the way, it wraps the neck. So the neck of the femur is intracapsular, is inside the capsule. So if you remember, the os coxa is made by 3 bones: the pubis, right, the ilium, and the ischium. So from each of those, we're going to have a ligament, right, which is really thickened capsule. So we will have iliofemoral, ischiofemoral, pubofemoral, and from the head of the femur, we're going to have another ligament which comes from the fovea. Remember the fovea, the depression on the head of the femur, or the fovea capitis? It will come from that to the center of the acetabulum. So these are your ligaments. In addition, we have also transverse acetabular ligament. So let's have a look here on how they look like. So pubofemoral, iliofemoral, and on the back we're going to have the ischiofemoral. Like you see here, they are really thickened capsule, and you can see also here that the neck, all the head and the neck are inside the capsule, inside this articulating cavity. In addition, we're going to have here the ligament of the head of the femur. If you remember anything round, what did we call it? Anything that's round? Remember that? Teres, right? So sometimes we call that ligamentum teres because it's round like a little hot dog here. Okay? In addition to those, we have, if you remember how the acetabulum looked like, it looked like a C, a downward C. And between the lips of the acetabulum, we're going to have at the very bottom here a transverse acetabular ligament which completes the whole circle, right? So that's our fifth ligament. So again, iliofemoral, pubofemoral, and ischiofemoral, and then we have ligamentum teres and transverse acetabular ligament. These are your ligaments of your hip joint. All right. Okay, and of course, even though it's stabilized by these joints, it is possible that it can dislocate, especially in an accident like a crash accident, where the head of the femur will not break, although it's a fracture. The fracture of the neck of the femur is fairly common, but it would rather slip out in an accident like you can see here. All right, so we move now to the knee joint. Knee joint is a diarthrotic joint between, it's a hinged joint between the femur and your tibia. The patella is there, but it's really, it's not part of your hinge joint. It's a very complex joint because it's taking all the brunt of your body, so you really, that joint you have to stabilize very well. You also have to cushion it well. How would you cushion it? By inserting in other fibrocartilage between the articulating disc, which are softer kind of cartilage, to cushion the shocks, to act as shock absorbents. And we have lateral and medial menisci. These are not single disc like the ones we had in the temporomandibular joint or the sternoclavicular joint, but they are C-shaped discs on each side, of one on the lateral side and one of the medial side. I'm going to show you pictures of that. And of course we have to stabilize the joint by extracapsular ligaments and intracapsular ligaments. Extracapsular ligaments like the patellar, the lateral collateral and the medial collateral, but intracapsular, that means ligaments within the capsule inside the synovial joint. We're going to have the anterior and the posterior cruciate, or what we call ACL and PCL. So let's have a look at the knee joint, and we can see here the menisci. I'm looking to show you better the menisci. Here we go. Here is the medial and the lateral menisci. You can see them here. Here is the medial and the lateral menisci. And again, the idea of having the menisci is to act as shock absorbent, is to control the space so you have limited motion and allows you to lock your knee, and we'll have other functions that we will discuss together in the next slide. But first, let's have a look at the ligaments. So the first ligament we have here is your patellar ligament. Then we have your tibial collateral, or what we call the medial collateral ligament, and we have the fibular collateral, or what we call the lateral collateral ligament. Those are all extracapsular ligaments. And then we have intracapsular. We're going to have the anterior and the posterior cruciate. The anterior cruciate, they look like crosses, that's hence the name, the anterior and the posterior cruciate. The anterior cruciate will prevent the forward displacement of your leg, the forward, so prevents the leg from sliding forward away from your knee, away from your femur, and your posterior cruciate will prevent the tibia from sliding backwards away from the femur. So once again, anterior cruciate prevents the forward displacement of the tibia. The posterior cruciate will prevent the posterior displacement of your tibia. So now to the menisci, as I told you, it will act as a cushion, it will reshape the articular surface, it increases the articular surface, and it provides stability to the joint as well. That's why your knee joint locks on when you are standing, and in part thanks to that menisci, which are fibrocartilage. And you can see here an MRI for your knee joint. And by the way, your cartilage doesn't show in X-ray, so if someone gets meniscus tear, an X-ray will not show anything. You're supposed to do MRI. Lateral blow or anterior blow or posterior blow to the knee can result in torn ligaments. The most common ligaments to be torn are the ACL and the PCL, anterior cruciate and the posterior cruciate. How do I know that the anterior cruciate was the one that got damaged? If I pull the leg forward, it shouldn't slip forward. If it slips forward, then it's the ACL that got damaged. If it slips backward, if I push on it, and if it slips backward, then it's the PCL that got damaged, or the posterior cruciate ligament. All right, the final ligament we're going to talk about is the talocrural ligament, which is the ankle, talocrural joint, which is the ankle joint. And we're going to see some ligaments holding the joint together. First, between the fibula and the tibia, we're going to have tibiofibular ligament. That's anterior and posterior tibiofibular ligament. That just holds the tibia and the fibula together, so they will act like a one bone together. Then I'm going to connect the fibula to the talus or to the calcaneus. So I'm going to have anterior talofibular ligament and posterior talofibular ligament. Again, between the talus and the fibula, anterior talofibular and posterior talofibular. And then we'll have between the fibula and the calcaneus, we're going to have calcaneofibular ligament. The three together can be called the lateral ligament. So the lateral ligament is the anterior talofibular ligament, posterior talofibular ligament, and the calcaneofibular ligament together. That's on the lateral aspect. On the medial aspect, I'm going to have what we call the deltoid ligament. That's between the tibia and your calcaneus, and also to the talus. So why do we call it deltoid? Because it's shaped like a delta. Remember the deltoid muscle? It's shaped like a delta. And that was our last special joint that we need to know the ligaments on. So if someone, for example, hyper-invert, that means you turned your foot under you, like you skipped a step and it fell under you, and you inverted your foot under your body, and that can result in damage in the lateral ligament. And the lateral ligaments, the components of it, is the anterior and posterior talofibular and also the calcaneofibular ligaments. Those can be damaged. If you twist it the other way around, so you hyper-evert your ankle, that can result into damage in your deltoid ligament. You get that? So over here, if you hyper-invert, you will damage the lateral ligament. What are the components of the lateral ligament? Anterior and posterior, talofibular ligaments, and your calcaneofibular ligament. And on the medial aspect, on the other hand, we have the deltoid ligament. So this is a summary of our lecture that we were not able to go through, or we will go through in the class, but in sort of a review format, and will allow us perhaps to discuss the joints more and the clinical aspect of these joints, and allow us more time for reviewing our material for the upcoming practical test. All right, thank you for watching this. I hope you find it useful. Have a great day.